A very good evening, everyone. My name is Khushbu Sharma, and it's my pleasure to welcome everyone. Today, we mark a very special initiative that Voice of Healthcare has undertaken under our annual campaign of VOH Better Health. It's an annual initiative to recognize International Women's Day. This panel discussion is exclusively in collaboration with Beckman Coulter Diagnostics on the subject of understanding anti-Mullerian hormone above and beyond conventional markers for women's health. Through this discussion, our experts shall help us in understanding more about the EMH test and its significance in the assessment of women's overall health and wellness. With this, I'd now like to warmly welcome the expert panel today. We have Dr. Matilda Merve Tuğlu with us. She is Scientific Marketing Manager, APAC and EEMEA region at Beckman Coulter Diagnostics. Welcome so much, Dr. Matilda.
Hi. Hello.
We have Dr. Manisha Singh. Ma'am is the Senior Consultant, Gynaecology and Reproductive Medicine at Fortis Hospital, Bangalore. Welcome, Dr. Manisha. Thank you so much for joining us.
Very good afternoon and hello to everyone.
We have Dr. Arunima Halder with us. She's Consultant, IVF and Reproductive Medicine at Manipal Hospital, Whitefield. Good evening, Dr. Arunima. Thank you so much for joining.
Thank you, and good evening to everybody.
We also would be joined by Dr. Nandita Palshetkar. She is the President, Indian Society of Assisted Reproduction. And also by Dr. Ruma Satvik. She's the Senior Consultant, Obstetrics and Gynaecology at Sir Ganga Hospital, Delhi. Both of us shall be joining us in the next couple of minutes. Dr. Matilda shall also be leading this panel and beginning the rounds of discussion today. So without any further ado, I'll hand it over to Dr. Matilda.
Thank you very much. Hello, everyone, and thank you for joining the Understanding Beyond the Obvious webinar dedicated to anti-Mullerian hormone. And also a special thanks to our distinguished panelists. As you may know, the anti-Mullerian hormone, also known as AMH, was recognized in the middle of 20th century, but the interest in this hormone increased only after 2002, when a group of investigators showed that the level of AMH in a woman's serum was correlated with the number of her ovarian follicles. And since then, AMH remains a hot topic for gynecologists for its crucial role in female reproductive health. There are many questions about the clinical implementation of this hormone. So during this webinar, we will discuss and try to address all these questions. And now I would like to open the discussion, and I will to start with Dr. Manisha. Dr. Manisha, please, can you tell us what are the factors that can affect AMH levels in women, and how can healthcare providers use this information to inform reproductive health decisions?
Thank you, Dr. Matilda. AMH is the hormone that is in vogue, and it's secreted by the granulosa cells. So the normal AMH range that we look for in women in the reproductive age group is anywhere between 2 and 6, and higher than 6 level of AMH. 6 nanograms is generally seen in women who have polycystic ovaries, and about 60% of girls in India have polycystic ovaries. But the concern comes up when your AMH levels are low. And that is what we see in women that have endometriosis, those that have had surgeries for different cysts in their ovaries, those that are heading for premature ovarian failure, and those women that have had chemo or radiotherapy will have low levels of AMH. Now, how does it really matter? Why does AMH matter today? Why is everyone taking notice of it? Why are all the women so savvy about knowing about their AMH and they seek more advice and help? It is because today women are career women, and they want to settle down in their career, and then they want to plan their family. So when they have a baseline AMH level, they want us to tell them, how long can I wait, doctor, before I think of having a family? So it helps women make their reproductive career choices. And therefore, the AMH level matters. Now, that does not mean that if you have a low AMH, that means you're heading in the direction of IVF or IUI or any fertility treatment, but it's a marker to tell you how much is it safe to wait and how quickly must you embark on your fertility journey. Also, it is important for us as clinicians to counsel patients. Say someone is having a surgery for endometriosis. I need to counsel her before I operate on her that if I do surgery and if I excise a cyst from your ovary, your AMH levels are likely to go down. And therefore, every patient must make an informed choice about going for a surgery and what will be the subsequent impact of undergoing the surgery on her egg reserve, which is estimated with the help of the AMH. And also in women with polycystic ovary syndrome who have a very high AMH level, if you're going to offer them gonadotropin stimulation or any hormonal stimulation, they have a risk of ovarian hyperstimulation. And this is what you can counsel the women about, that you have PCO, you have a high AMH, I stimulate your ovaries, you are likely to run the risk of ovarian hyperstimulation, and what's the impact of that. So these are all the points that come up when you're discussing various aspects in relation to fertility with any woman today.
Thank you very much, Dr. Manisha. It seems that there are many factors that affect the AMH levels. And now I would like to ask Dr. Ruma. Welcome, Dr. Ruma. How does AMH relate to female fertility and ovarian reserve? And what are the implications for women who have low AMH levels?
Right. So I think Dr. Manisha has already outlined how it signifies the importance of how we tailor make our treatments, what it might mean to women who are undergoing IVF. But I think one point which I would like to add here is so let's say we have, and this is a very common scenario, women marrying late, let's say a 35-year-old woman comes to us, has been married just for 4 months, has probably the husband and wife don't live together and they are in separate sort of towns. They probably meet irregularly, probably 4 days or on weekends. And because she's married late, she's probably worried that she wants to conceive, and she probably consults a doctor, wherein this is the first test. They order, okay, let's, you look fine, your history looks okay, but let's also do an AMH to test where you are with respect to your, what end of the fertility spectrum you're on, high, low, whatever. So they do an AMH, let's say, and it comes out to be whatever is considered normal for that age and less than that. So let's say for a 35-year-old, the value was. Can you still hear me? Hello?
Yes, we can hear you.
Right. Okay. There was just a shift in the frames. So, and now she probably starts panicking because she's been told that this is a very low reserve and that your chances of conception are low. You need to try treatments right away or whatever, right? So my point here is that AMH alone should not be used to counsel women. Duration of trying has a major bearing on how women's fertility would be. Someone who has not tried enough, and that would be at least 6 months for a 35-year-old, one should not start panicking, right? Even at 0.8 AMH. So most women, even at the age of 35, will look at their graphs, should be able to conceive even with low AMH naturally. It's the duration of trying as well, which needs to be stressed upon. So a 35-year-old trying for 1 year with a low AMH has a different prognosis from a 35-year-old trying for 2 months with a low AMH, right? And both of them are very different categories. We can counsel them separately. I would agree with everything that has been said by the previous panelists, that it is an important marker when we do decide to treat these women. And the treatment will start probably a year or 6 months in an elderly woman, but at least a year after trying in a woman who's younger than 35. And this is a separate subset from a woman who has been trying for a very short duration of time, right? So I'm trying to stress on the importance of duration of trying as well, in the absence of any pathology, in the absence of any, let's say, prior surgical history. It's perfectly all right to ask women to go home, try again, maybe 3 months, give them what is known as the fertile period, and ask them to try till at least whatever that duration of 6 months for a 35-year-old is over.
Thank you very much, Dr. Ruma, for this interesting information. And now I would like to ask Dr. Arunima. We heard from Dr. Ruma about younger women, how should approach, but Dr. Arunima, how does age impact AMH levels? And what are the implications for women who are trying to conceive later?
Hello, everybody. So, age does have impact in AMH, and we already have seen so many studies. There are several studies which say in what way the AMH actually falls. So, some studies say that there's a steady fall up to 38 years of age, and after that there is a rapid decline. There are studies which say that there is a decline by about 6% per year. There is one study which says that the annual decrease in AMH level is approximately 0.384 nanogram per ml. So there are various studies. Even in South Bangalore, we have seen one study which said that women who were around 30 to 34 years of age, they have basically divided the group of women in 30 to 34 age group and 35 to 39 age group. So in the 30 to 34 age group, they have seen an AMH of less than 1.1 in 21.5% women. And as it goes to 35 to 39, the percentage increases to 45.5. So AMH, this was a cross-sectional study, so AMH does decrease as we get older. So how to count and what basically implies when we are looking at a person who is having low AMH with age as a factor. So like Dr. Ruma was saying, AMH cannot be, individually attributed to as, we can't say that because of a low AMH you will not become fertile, or there is no chance of pregnancy. Because I have actually learned it in a hard way. I had once counseled long back. I had counseled one patient. You have an AMH of 0.8. There will be difficulty in conception. Soon she went home, stayed with her husband for 3 months, and the COVID had come at that time, first wave, and she conceived naturally. So that was how I learned that this is not going to, I can't counsel patients in this way. So what to counsel these patients who are of a like elder age, more age, but with low AMH? So first and foremost, these people will, so AMH tells only one thing, that is very sure, very clearly it tells one thing, that the output of follicles, the number of follicles that we get, the number of eggs we get will not be that much. So it gives us a prognosis about the ovarian stimulation. So we may expect that we will get lesser number of eggs. That is one thing. Because of the age, because of the non-disjunction of chromosome and various other factors like increased ROS, etc., we may get a poor quality egg for these people, because of which we may get a poor quality embryo. The third thing, which is more commonly seen with people of higher age group, is having empty follicles. So I had one patient. She was 41. Her AMH was 0.2. So she had undergone she was very keen of going ahead with her own eggs. So she had undergone one cycle. There were 6 follicles. She got nothing. After that, she came to me, where I also, since I was very brave enough. I started going ahead and went ahead and did a conventional stimulation for her. I got nothing from her. Then with mild stimulations, we got one or two eggs like that, and that's how we collected those eggs for her. So what I mean to say is it's more common to have empty follicles in these women, in the women who are elder. Other thing with AMH is that when the AMH starts decreasing, we have a luteofollicular transition which is happening earlier. So we have early recruitment of follicles. So for which you will have to go ahead and see the patient earlier. You can't really wait for day 2 or day 3, which is conventionally done. So you may get a very asynchronous growth of follicles if you start late for these patients. Other thing is that because these patients get a lesser number of follicles, you may end up doing some pooling for these people, which again increases the cost of IVF. So yes, AMH cannot be directly, we can't counsel with AMH that your fertility rate will be poor. But definitely, when age is a factor, it worsens the fertility rate.
Thank you very much, Dr. Arunima. What I heard for you is that age is important, but it is not only age. There are many other factors beside this factor. So, Dr. Ruma, how does the use of AMH testing fit into a broader approach to women's health, including the preventive care, fertility treatments, and overall wellness, we may say?
Right. So outside fertility, is that your question? How
Sorry?
would one use AMH testing
How does the
outside?
use of fit into broader approach? For example, including preventive care, fertility treatment, or overall wellness of women health, we may say.
Right, right. Yeah, so I believe one of the panelists has already spoken about how one could use AMH prior to the surgeries that one does on the ovaries in order to determine uh, what the reserve is and how much reduction to expect. Although and this is can be a point of counseling. Sometimes low AMH in women with endometriosis who are also subfertile but needing treatment for severe pain or endometriosis per se, and undergoing surgery, you would want to adopt a more sort of conservative approach in terms of removing, let's say, a lesion in the ovary rather than going very radically and removing the lesion more aggressively. So you adopt a softer approach in terms of treatment of ovarian lesions in women with lower reserve. Uh, the other is perhaps AMH has also been used in women who have very high values, and this is abnormally high values, something approaching 50s or 60 nanograms or higher. Anything more than 10 nanograms, I would start suspecting an ovarian tumor and would want to investigate. Of course, radiology, X-rays, ultrasounds, MRIs would be more diagnostic here. Then just to the previous question that I wanted to add here is like zero point 0.8 AMH in a 20-year-old, 0.8 AMH, 20-year-olds don't undergo infertility treatment, but 0.8 AMH in a 25-year-old, 0.8 AMH in a 30-year-old, and 0.8 AMH in a 35-year-old, all of them with, let's say, the same duration of trying 1 year each, will have different outcomes in IVF. So it helps us in counseling our patients as well, based on their age, duration of infertility, and AMH values on what to expect during an IVF cycle. So younger woman, low AMH will do much better than an older woman, same AMH. So we do use AMH in many kind of scenarios, surgeries, fertility, women undergoing fertility preservation surgeries, let's say, or fertility preservation cancer treatments. So those are the women, let's say a young woman with very high AMH undergoing chemotherapy for breast cancer. Uh, could, and where the drugs are not very toxic, because drugs also come in different categories. One would be a highly toxic gametotoxic drug. The other could be a moderately gametotoxic drug, and third is a low gametotoxicity. So in such women, you can counsel the woman that your drop in fertility, if the AMH is high, may not be as huge, because what we are talking about in terms of fertility preservation are, freezing their eggs, and freezing their eggs for long duration of time, wherein we still don't know the effect of how 10 years or 15 years of freezing, what bearing will it have on the fertility potential of the frozen eggs. So is it really exercise? That is something that needs to be studied. It is a topic that we still need to be able to have enough information on to be able to counsel the woman. So definitely a young woman with a very high AMH undergoing chemotherapy for cancer through drugs which are not very gametotoxic can be counseled that your fertility drop is not going to be severe. There is a good possibility that you will retain your fertility post chemotherapy. That you have the option of not undergoing fertility preservation. That's one. Or, of course, the option remains, wherein the freezings can happen for 10 years. We don't know the effect of how the gametes would behave 10 years later, but yeah, we have that option for you.
Thank you very much. Very interesting information. And we have Dr. Nandita with us. Welcome, Dr. Nandita.
Thank you. I'm sorry, I was caught up in another program.
No problem at all, Dr. Nandita. May I ask you a question, Dr. Nandita?
Sure.
Okay, then. What is the anti-Mullerian hormone in general, or overview? Can you give us an overview? And why it is an important marker of women's health beyond the conventional other markers of anti-Mullerian hormone?
See, personally, I am a great proponent of anti-Mullerian hormone. I feel that it is a very important test in women's health, and over the past 1 decade at least, it has really the test has become more streamlined now, and we can depend on it. And I've been using it as an ovarian reserve marker, especially in my fertility patients. And we've done a lot of tests and a lot of research where we correlate the ovarian reserve with the number of eggs which we get with vis-a-vis the ovarian, the AMH levels. So AMH is a blood test which we do in the woman. We can do it any time of the period, and it tells me her ovarian reserve. So whether, the number of eggs, it's the quantity of the eggs. Unfortunately, it's not the quality of the eggs. The quality usually depends on her, age. And of course, if there's any disease process or pathological process that has affected her, like PCOS, endometriosis, or even chemotherapy, which she's taken. But AMH is a fantastic tool in our armamentarium now, and when combined with the ultrasound, I think it's fantastic and gives very accurate results as to the ovarian reserve and the fertility potential of that girl.
Yeah. Thank you very much, Dr. Nandita. And now I want to ask Dr. Manisha. Dr. Manisha, how can women use AMH testing? How can we use AMH testing to plan women's future reproductive health, and such as deciding when to start a family or considering options like egg freezing? Dr. Manisha? Dr. Manisha, I think we lost Dr. Manisha. She will join us soon. Then, Dr. Arunima, may I ask you, what are some of the ongoing research and development in the field of AMH testing? And how might this advance change the way we understand and manage women's reproductive health? You are on mute, Dr. Arunima. You are on mute.
I'm so sorry. So before understanding what is the ongoing research on AMH, we need to understand a little bit about the history of the AMH testing. So AMH testing, the first generation assays were the DSL assay and the Immunotech assay. So initially all these assays were manual assays. So later on, Gen 2 assay from Beckman Coulter, it came up and it took over those assays. It was still a manual assay, but it has started to give much dependable results. Later on, around 2013, Ansch Labs, they came up with something called as ultra sensitive AMH assay, using a new pair of antibodies against the AMH value. Now, all these assays, they were not really giving a standardized result. We There were two more assays which came up. Now these were automated assays. One was the Axis AMH assay from Beckman Coulter, and the other was Alexis, which came up from Germany. Roche group took it. So even then, there was a standardization problem. I'll tell you what happened with me. One of my patients who had come from Nigeria, she came with her reports, and I saw her. She had fibroids in the uterus, and her AMH was 2.2. So in the first meeting, we talked, and I counseled her that once the fibroids are removed, we can go ahead with an IVF for you. So to understand what is the situation of the fibroids, I went ahead and did the scan for her. When I did the scan for her, I really couldn't see any. There was no follicles in either of the ovaries. One ovary was so small I could not even see that ovary that well. So I asked for an AMH. The AMH value here, we are using the Alexis assay here. So we got a value of 0.02. So that changes the form of treatment, right? So in two different countries, and it was a very recent report which she got. So in two different countries, we got such a varied result. So there was a study in 2016 which compared four assays: the Axis AMH assay, the Alexis assay, the AMH Gen 2 assay, as well as uh, uh, the ultrasensitive Ansch assay. So what it found was there was not much variability. The variability came more when these samples were stored and collected, frozen and thawed, and that gave a variability, especially with the Gen 2 related assays. The Alexis and the Axis assays both were kind of similar results, but the ultrasensitive assay gave a higher result. All these assays were working well for the PCOS range AMH, but not very well for the lower AMH. So, so much so that the ultrasensitive assay gave a difference of around 1 nanogram. So that's a very large clinically significant assay difference. So a 1 nanogram difference between 2 ng per ml and 1 ng per ml gives a stark difference in the clinical outcome, right? So the current, we have good assays now. Both the Axis AMH assay as well as the Alexis assay are quite dependable, quite standardized. They are both standardized to the previous Gen 2 assay, but still lot of standardization is required. So the latest thing which people are looking into is probably getting a reference based on recombinant human AMH. So once that comes and all these assays are standardized to that, probably we'll get a worldwide uniform assay. I also do feel that there is a need for one more thing, especially in the Indian this thing, the Caucasian AMH levels. All these data are mainly Caucasian level data, right? The Caucasian AMH levels are slightly different from Indian. So there are several studies which say that ovarian aging is earlier in Indian women, etc. So I do feel that a lot of studies are needed. There is one pan-Indian study existing which says that there is a trend towards lower AMH in India earlier as compared to the Caucasian. So once this kind of study comes in India, probably we will be able to, counsel our patients much better as compared to what we are doing now.
Thank you very much, Dr. Arunima. Just because you talked about some essays available in your country, just to add that the Access AMH test is a test that uses a recombinant human AMH and also uses a synthetic matrix which is completely free of endogenous AMH, I want to say. And Dr.
Yeah, I
Manisha,
also want to say something. I have just found out that we were sending our tests to the main Manipal branch here, which has Alexis Roche. So Manipal Whitefield branch is getting a access AMH test very soon.
thank you very much for sharing. And Dr. Manisha, welcome back. We lost you, but
I know.
welcome. Now, Dr. Manisha, I would like to ask you, how it is possible to use AMH testing to plan future reproductive health for a woman, and such as deciding when to start a family or considering options like egg freezing?
So, Matilda, I think a lot of questions are overlapping over the panelists. I think some of these answers have already been given by me, Ruma, and Arunima. But just to recap very quickly, all women are born with a fixed reserve of eggs, and there is a monthly outgoing, there is no incoming. And as long as you have an egg that is being ovulated every month, you have every chance and opportunity to get pregnant, because pregnancy and fertility, these are gray zones. There is no black and white that can tell you that because your AMH is this much you can't get pregnant, or it doesn't work like that. So AMH is a rough marker. Of course, we use it in conjunction with the antral follicle count whenever we see a woman in the clinic. And today, as I said earlier, in my previous answer, that women are more career oriented and they want to delay their childbearing prospects until a little bit later when they're more secure in their jobs and homes. So, yes, today we can use the AMH as one of the markers to assist them and guide them as to whether they should consider egg freezing, which is a very viable option. Of course, how long you can do it, I don't know, but we currently have people who've frozen for about 5 years. Um, and they have, some of them have come back to have these eggs then put back into their womb to conceive. But long term, beyond 10 years, etc., I do not know. But embryos, yes, we have frozen for much, much longer. So those that are single and just want and have no partners, they can consider egg freezing. Those that are in a steady relationship and wish to, conserve fertility, they can have either their eggs frozen or they can have their eggs fertilized with their partner's sperm, and they can have embryos cryopreserved. Cryopreservation of oocytes is certainly a very good option that needs to be discussed. As Ruma mentioned earlier, for those that are undergoing chemo or radiotherapy prior to the onset of all of these therapies, of course, there are many patients who have a decent egg reserve and they have less cytotoxic, gametotoxic chemotherapy, and their ovaries can spring back to life a couple of years after completion of the chemoradiotherapy, and they can go on to conceive. And I've had a few patients who have conceived spontaneously a couple of years post chemotherapy, and they've done absolutely fine, brilliant babies. But yes, if you want eggs that are not, affected by chemoradiotherapy, you want nice clean eggs, you can just come for cryopreservation. If you are worried that if you are older and the egg quality deteriorates and you have a higher chance of having a baby with aneuploidy Down syndrome, etc., and you don't want any of that, then you can have your oocytes cryopreserved when you are younger, and then you can use the oocytes later whenever you're ready to start your family.
I
Thank
think,
you.
Matilda, can I add over here a little
Nandita,
bit?
sure,
Yeah,
please.
I think Manisha has covered a lot, but there are some patients which we are seeing now with low AMH, and when you stimulate them and you get really 3, 4 eggs only, like I had a patient who was actually a doctor and she was monitoring her AMH, and since 1 year the AMH has dropped from 2.2 to 1.1. And yesterday she came to me and she was very distressed. So this AMH is causing a lot of distress also, the dropping levels. probably because of stress, because of pollution, etc. But where the egg freezing is concerned, I think what we have is a fantastic tool which is now available for all these girls who want to just freeze their eggs. If they have low MH, they've given us less eggs. We can actually do artificial intelligence. The programs which are there now actually give you a live birth rate per oocyte, and that way we can actually advise these girls that you need to do one more cycle of egg freezing. Supposing she's just given you 4 or 5, and it feeds in everything. It feeds in the age of the girl, the the number of eggs, everything. And you can definitely do multiple cycles of egg freezing so that you can reassure her good live birth rate. So I think this use of technology with our expertise is really fantastic, and I think that has really changed the practice that we are doing right now in infertility. So AMH has been a boon for us, absolutely a boon for us, and combined with technology, it's really helping us help all our patients.
I think I agree with Nandita, but there's just one point is the cost implication of doing stimulation and freezing, and everyone needs to have deep pockets to go through multiple cycles of stimulation and egg freezing. So I think that also needs to be factored in when we counsel patients about oocyte cryopreservation.
A lot,
Sometimes it
lot
is
of
nice to advise women that they might actually be in a position to multitask, and they may be able to start their family a little bit early. At the end of the day, if you have an egg that can lead to a pregnancy, we are all the products of one egg and one sperm. So never say never. Hope is what we live for. That's it.
No, I think Manisha, you're absolutely right. But today there are a lot of units doing budget IVF, and there are cycles which can be done for 10,000 rupees with drugs. So there is a lot of options available. That's what I want to give the
Oh,
message to
absolutely.
everybody.
I don't deny. I don't
Yeah,
deny. But for some people,
you
even
know,
that 10 grand may be a little bit more.
mm,
And there is
no,
a
but
lot
a
of women who
lot
are
of
now
lot
on
of
the
units
career
who are
path.
doing it free. Lot of units are doing it free. The hospitals of government colleges and all, they're offering it free. So I think we should not close our minds, and there are a lot of organization, charity organizations. ISAR is giving a lot of help to people, so please do apply to ISAR with your free patients, and if they're eligible, we will reimburse them the money, definitely. So I think we can really do that.
Oh, that's fantastic. That's nice to know.
Yes.
Thank you. Thank you
Thank
very
you.
much,
Thank you.
Dr. Manisha and Dr. Nandita, for sharing your perspectives on this. And I have one question for Dr. Nandita. Dr. Nandita, what are the current and potential future applications of AMH testing in women's health beyond fertility, such as in predicting menopause timing or assessing risk for certain health conditions?
I am doing a lot of work on aging, and I think aging has its implications. Uh, and reproductive aging is a precursor to any aging in the body. The ovary ages twice as much faster than any other organ in the body, and our AMH kind of indicates how quickly the ovary is aging. And if that gives us an indication as to how the woman will start aging, it's kind of there was a beautiful article, which was that article where the woman's I think there was a lot of research done even in Harvard where they studied all the organs except ovary. So, no importance is being paid to ovary. So, I think the AMH is going to become a very useful biomarker in the future, because the AMH will actually indicate that ovarian aging has started, and ovarian aging starts twice as much earlier than the other organs. So definitely a woman who spends her after reproductive aging, half her life goes in. After that, actually, the hourglass turns, and she spends her life in menopause, and all these cardiovascular events, the bone events, the thromboembolic phenomena, everything, all the problems that she has. So I think AMH right now, it's not being used accurately to predict, but I think it has a great future, because the ovary is very important, and it is one of the biomarkers of the ovary.
Mhm. Thank you. Thank you very much, Dr. Nandita. So far, thank you very much for this great discussion. You already shared your experience with us, but I want to ask if you have a special, any a difficult patient case you want to share with us, and how AMH helped you to manage this patient case. So, Dr. Ruma, do you have any such a case you want to share with us?
I can't immediately think of any. I mean, I use AMH a lot, but as a special case, I can't think of any. Maybe you can take the question to the other panelists.
Okay, then I would like to ask other panelists in case you want to share any special case, patient case. Yes, please,
I
Dr.
think, the special case that I really would like to share is of this 42-year-old girl who came to me, and she had tried multiple attempts abroad, and she had come to me at the end of it because her surrogate would not get a visa to go abroad. And then when we checked her AMH, she was, I think she was 43 at that point, and her AMH was, how much? I was amazed. It was 4.5 nanograms per ml. And it was so amazing because at that age to get that AMH, and we got a lot of eggs, and we were able to, otherwise at 44, we would just tell the patient go for egg donation. I think AMH had just come in that point, and that is when we told her, no, go for your own eggs. Of course, the ultrasound did help, but AMH along with ultrasound really helped us counsel that patient. See, she had multiple failures of IVF, so AMH helped build up that confidence. No, we must go again, and we must give the best lab conditions and give her a chance to try and conceive on her, with her own oocytes. And I think that confidence which AMH has given over the years, this was right at the beginning, lots of years ago. I think that really changed the whole reproductive medicine line, and it has really individualized treatments and made it much safer. I think it's really helped us do a much better job with our women.
Mm-hmm. Thank you very much, Dr. Nandita. So you think there is some space for AMH for individualized treatment, right?
Yes, definitely. It's one of the things I pay attention to, definitely.
Mm-hmm. Thank you. Thank you very much.
Dr. Nandita, may I ask you two questions? I was very interested in, I'm sorry I'm hijacking.
Yeah, I know. I
Sure,
have to know.
Yeah, there's one on what do you feel about, let's say, a 44-year-old with a good result, a woman who will be undergoing IVF. What are her risks of aneuploidy? Are they the same as a 44-year-old with normal AMH for her age? So let's say a 44-year-old with an AMH of 0.5 versus 44-year-old with an AMH of 4.5. Of course, we'll get more eggs, but in terms of aneuploidy, do you think there will be a difference?
You know what? This is a very tricky question. Age-related aneuploidy should be the same, but the lower AMH is supposed to cause more aneuploidy in the eggs because the oocytes are, there's a lot of damage. There's a lot of damage probably because of aging, probably because of environmental toxins, those kind of things. So I feel it may be slightly more in a person who has a low AMH, but the one who has a better AMH would have a normal fertile woman who has a chance of 1 in 100 at the age of 44 plus of aneuploidy. I mean, that's the point she would have. But the one who has a low AMH, I think she would have a slightly more. But this is not evidence-based. This is logic-based, what I'm talking.
Right. No,
May I just add one point here, Ruma? Just one point.
Yes.
Is that if you have a low AMH, you have a tendency to use a higher dose of gonadotropin. That is what most people would do. And the more the gonadotropin usage, the greater the spindle defects in the oocyte, in the meiotic division. And therefore, you have a higher chance of aneuploidy in these embryos than you would have in someone who went out to conceive on their own. Age-related risk would be absolutely the same. But if you look at statistics, whatever the risk you give a person, so you say a 1 in 10 or a 1 in 100. For every individual in that group of people, the risk is a 50-50. So that's the bottom line.
But I believe there are papers published very recently, last year or the year before that, which actually link a high AMH to low aneuploidal rates. So it's interesting that Dr. Nandita brought
Yeah.
up the case. And the other question I had again for Dr. Nandita was, do you think a low AMH is more the effect of accelerated aging, or is it the cause of accelerated aging?
It's the effect of accelerated aging, I feel personally.
Okay.
It's the effect of accelerated aging. Because see, the follicles, the antral follicles are dying. There's apoptosis or whatever is happening inside. They are turning atretic. And that is what is causing the AMH to reduce, the secretion of the AMH to reduce. This, the primordial follicles are probably not growing into antral follicles.
I think the changing lifestyle also matters. There are more people who are smoking today, and that directly has damage on your ovary, and that cuts down your AMH. And therefore, one of the advice we give to every girl is that if they are smokers, then they need to quit if they
I
are
feel,
interested in fertility.
I'm sorry, ma'am. I feel that it's almost like a vicious cycle. AMH has a protective effect on the ovarian reserve. So as the follicles start escaping this protective effect, the AMH comes down, the number of follicles totally comes down, and AMH is actually released from those follicles. So eventually the AMH comes down. So it keeps going on, and probably that's how the ovarian aging starts happening.
No, no. See, you know what? Because what happens with aging is either the follicles die in that primordial phase only, or more are recruited, so that
Yeah.
then they degenerate on the way. So that is the accelerated destruction of the follicles that happens, and that is why the AMH keeps dropping. That's what I feel. That's my personal take on aging.
I have one question for all the panelists. A patient, we have not really touched about PCOS here, high
Yeah, yeah,
AMH,
yeah.
how we can, prognosticate the ovarian stimulation in PCOS. So if we have a patient of an AMH, say, of 12, 14, and you have a patient of AMH 21. So what is the approach for these patients?
Go ahead, Manisha. Then I will talk after you.
It all depends. I mean, I'm a big advocate of monofollicular stimulation, so I would maybe offer them an LOD first, and then see whether it's unlikely these people will have natural cycles. It's possible that they are oligomenoric, anovulatory. So my first approach would be, using LOD with simple stimulation, letrose, clomiphene, whatever you have, before you embark on the journey of IVF. That is what I would do. And of course, there are other medications that you would use in these patients, insulin sensitizers, before you start IVF. And then maybe when you go for IVF also, you would have to tailor make it to how their responses are. You would have to titrate the gonadotropins accordingly through the cycle. Otherwise, they'll end up with plum OHSS. So I think I worry more about the lean PCO than the obese PCO, because the obese PCO, you can at least tell them lose weight. It's the lean PCO that are very brittle. They are hard to manage. They hyperstimulate, and they end up with OHSS. So that is the group I worry about the most, the lean PCO. But yes, I think first would be, diet, insulin sensitizers, LOD, simple oral stimulation, and then move on to gonadotropins in whichever way you like, is what I would do.
So I personally would think I would prefer to go for IVF in these, because it'll be very difficult stimulating. Oral, I would do whatever Manisha has said, but I would switch to IVF, because in these patients, I mean the phenotype A especially, would definitely go for OHS, land up with OHSs. So with IVF, at least I can control that. So, titrate the dose. I would start with, I prefer sometimes to use the minimal stimulation. You use letrozole with gonadotropins and see how many follicles I can get with that type of patient. Or then, that's one protocol I try. Or then I try 150. 150 is the general dose I try. If they're very, very lean, then 75. But then if I land up with monofollicular, it's a real pain. So it's a trial and error. But I would prefer IVF in such patients, frankly. I mean, I wouldn't give too much trial of natural because they land up in trouble. As Manisha said, they can just create a time bomb and land up with the OHSS. So go for IVF, freeze, use a GnRH analog trigger and freeze all the embryos and go for it. That's what I would do. Letrozole plus gonadotropins I would try first in that 20 plus, AMH or just 75 to
The patients
150.
I cater to, Nandita, I find it very hard to convince them to go for IVF. It's a tough lot in Bangalore. They're very difficult to convince that they need IVF.
No,
So
but generally
we
what
do
happens is,
everything that's
yeah.
available, and it's the IVF is the last and final resort. I
No,
can't get
probably
myself.
Manisha. Yeah,
Uh,
I don't get patients for IUI. That's the problem. I get all failure patients. So, it's usually they've tried everything and landed up with me. So then I generally head straight for IVF. That's the whole thing. So with this kind of a high AMH, I feel IVF really works well.
So, Arunima, I would
Yeah.
also like to come in here. Hi. So, it's a challenge stimulating these women, as
Yeah, yeah.
Dr. Nandita has said that they'll either make too many, and because of the high AMH and the reasoning that you were giving, that AMH actually prevents primordial follicles from moving into the next stage, which is secondary. So it's stopping that transition as well. So the minute you kind of increase your dose, you see the ovary blooming, and the minute you kind of lower it, you see no response at all. However, my first approach is not to kind of to take up the challenge. I would want to take up the challenge wherein we try and go in for maybe one follicle or two follicles. And here, one would have to look at a lot of things, including patient weight, BMI, which becomes a very important kind of determinant of what dose you would want to use in such a woman. So one can start with clomiphene citrate or letrozole, as the case may be. For me, clomiphene citrate still remains a favorite. I use that a lot. I might, depending upon the weight of the individual, BMI, want to start with either 2.5 letrozole or 5 milligrams to start with, or 50 milligrams or 100 milligrams of clomiphene citrate, like I said, BMI. So 10 days or 12 days later, when we do the first scan, or 5 or 7 days after the last dose, and you find that the cohort size has risen from, let's say the baseline cohort size was 5, and now the cohort size, more or less, most of the follicles have risen to 10 or 11 mm. I want to wait and see how they are, let's say by day 14 or 15. 2 weeks after the last dose, if nothing has moved, right? If you still are at 10, 10, 11, whatever, herein perhaps I would want to add gonadotropins in low doses, start with 75, and then sort of take it on from there. We do get single follicles in these women as well, right? I would agree with Dr. Nandita on the thing that some of them will end up, despite the care that you are taking in stimulating these women with, blooming ovary on both sides, in which case either you cancel or you counsel for an IVF and all of that. But IVF is not the first approach in my case, I mean, in such women. So I would also, what Dr. Manisha said about LOD, wherein you are actually kind of reducing a little bit of the AMH levels by targeting those areas between follicles. And that is likely to improve the responsiveness of these follicles to endogenous FSH, or the FSH that is likely to rise by your treatment with oral ovulogens. So that is also one approach in someone who's has that level of AMH, perhaps you won't be causing too much destruction in this woman. So LOD for me is, I don't use it literally. I use it very, very reservedly. And in a woman who is unable to kind of maybe take that decision between whether IVF would be, I'm okay with either this or that, perhaps LOD here is a good choice. In such women where despite your best efforts, you have been unable to give her that one follicle that she wants per cycle.
Thank you, everyone. It was nice to know everybody's perspective. I don't think I have any more time to ask another question, so I leave it to Matilda.
Dear panelists, thank you so much for this great discussion. We can possibly extend more, but I see that we are just on time. I may say that future of AMH seems to be bright and has a lot of interest. And as new studies and development continue in this field, I believe there will be more space for discussion. So once again, thank you very much.
Thanks a lot.
Thank you.
Thank you. Thank you.